Recording in progress.
So to finish Unit 1, it's Chapter 4, which is just general stress, which is obviously a useful concept to talk about. I think I have seen things scribbled on the walls that you all have talked about aspects of that, but it'll be a nice refresher nonetheless. And I know many of you all have talked about pain. So we'll for sure do Chapter 4, and then we may introduce parts of Chapter 6 to lead into next class, to Tuesday. All right. Objectives that you may or may not look at, which is fine. So with Chapter 4, what we're really looking at is how does the body handle an adverse environment. But when we say environment, we can mean both what comes in from the outside, but also the stresses that the body produces itself, right? Not all stressors are the same. Some are positive, and these are eustress, and some are negative, the term distress. And so what happens is when the body experiences stress, there's a physical response. And if you think evolutionarily, what this means is a stress to a Neanderthal would have been a saber-toothed cat or whatever would have been at the same time. I lose it. There would have been a threat. And so the body is conditioned to do one of two things, either flee or fight. And they both require kind of the same types, the same promotion of it. And now we are in much less a position now to need to run from an animal that wishes to eat us, but our body still has those responses together. And this is why exercise gets lumped into this chapter, because exercise itself is a stressor. It can be very often a positive stressor or a eustressor, and we'll introduce that there. Stresses are not only physical, which is what they are arguably easiest to talk about, but stressors can be emotional or mental. Many of the same physiological responses that occur with physical stress can also occur with emotional or mental stress. And so there is definitely a mind-body connection that can be viewed at holistically, and alternatively, physiological conditions can feed back and affect one's mental state and emotional state. Stresses can be acute, and these are going to be stresses that occur after an intermittent stimuli. So a sudden jump, somebody jumps out from behind the shadows to scare the crap out of you. That's an acute one. And what happens is that depending on the stimuli, you might have a variety of intensities in that response. But then once that stimulus is gone, once you realize it's your friend, you punched them in the face and they've gone away, your body returned, or in a healthy stress response, your body returns to normal, right? The stimulus, the response goes away. Excuse me. Chronic stress is more insidious, and chronic stress is a prolonged activation of your stress responses because the threat does not abate. Chronic stress it's kind of like inflammation, right? We talked in immunology. An acute inflammatory response is good. A chronic one is probably bad. Acute stressors, can be tolerated more often than not, whereas a chronic stressor is going to have detrimental effects. And in fact, chronic stress is associated with incidences of cancer, heart disease, depression, a variety of other illnesses. And importantly, chronic stress, if you are chronically stressed, to bring it back to immunology for a second, your immune system is depleted, because one of the stress hormones we produce during chronic stress is that cortisol. And cortisol is a corticosteroid, which we talked about how those work to suppress immune cells, as a manner of therapeutic. Well, in this case, you are suppressing your immune system because the body's like, hey, we have this stress. We don't need to worry about fighting off an infection because we are terrified of this thing that's trying to eat us. Your immune system can wait, but the threat never goes away. So the first is cells stress. The first theory that kind of describes the events of a stress response is cells developed in the 30s and 40s, and it can also be called a general adaptive syndrome. And what it speaks to is exposure to a stressor and then the events that occur following that. A stressor is anything that challenges the body, that invokes this physiological response, and the adaptive ability of an individual speaks to how well they will respond to that stressor. You might see this as like a coping mechanism. How well can they cope with a stress? We can mean that both from a behavioral standpoint, but also from their body's physiological mechanism. And the whole goal of responding to a stressor is to induce a response and then come back to normal. So we need to maintain homeostasis throughout it. In sales theory, you have the stress response involving neural and endocrine and immune aspects. Again, just like in inflammation, in the short term, this stress response is protective. But should that stress response continue, the threat never goes away, or the perceiving of the threat never goes away, it slowly stops being effective and starts to become detrimental. And we split this up into 3 groups: the alarm phase, the resistance phase, and the exhaustion phase. In the alarm phase, this is the first blush with it. So here you're going to have the activation of that sympathetic and of the autonomic nervous system, right? And so our central nervous system is going to see it. Our sympathetic nervous system is going to see it. And then our adrenal glands are going to respond. And so the sympathetic nervous system, upon immediate stressor influence, is going to release norepinephrine, which is one of our catecholamines. And it's one of the key drivers of the fight or flight response. And so think, what do you need to do when you are trying to flee from a danger? You need to be alert. You need your heart and lungs to increase. You need your pupils to dilate, because when you are trying to flee, you don't need to see one thing very specifically, which is what happens when you constrict. That's why when you read, your pupils constrict down to see the words and you lose the background. In a stress response, you want your pupils to be nice and wide so that maximum amount of light comes in so that you can see the most amount of stuff, but you don't see that stuff incredibly clearly. And so that's a trade-off, like, where's the bear coming from? Your gastrointestinal tract decreases in its activity, which kind of makes sense, right? If you are fleeing for your life, your body is not worried about processing and pooping. Like, the more important thing is to make sure skeletal muscle has the blood flow and the energy it needs. So you actually divert blood flow away from the GI tract and you put it towards the active skeletal muscle. You also increase sweat. And so you do this. That's why when you're stressed out, some people are prone to sweating. You also decrease your urination, right? You don't need to pee necessarily if you're trying to flee for your life. Notwithstanding all of the scared crapless jokes that can occur, but that's kind of like a different set of events. And we increase sweating. I think I trailed off there. We increase sweating because when you are actively fighting or fleeing, your body temperature is going to be going up because you're more active, your skeletal muscles burning, and by increasing sweat, you can keep that temperature as normal as possible. In all of these events, you need to try to keep the body in homeostasis as much as possible. So the sympathetic nervous system, those sympathetic nerves are going to start to release norepinephrine that primes the body to fight or run, to be highly active. In the endocrine system, when it gets activated, you get the hypothalamus, which is releasing CRF. Anterior pituitary gland is releasing ACTH, and these are going to drive the adrenal cortex to release cortisol. And this is what lay people would call the stress hormone. What cortisol does in the short term, it actually is an immune booster. It makes immune cells operate really well in a very short term. So we have a threat, we have a big, a stressor could be a big gash, during that response. Our immune system can go in and try to suppress it very quickly. Should that continue in the long term, it becomes an immunosuppressive. Cortisol also in the short term increases the delivery of blood from liver and skeletal muscle stores. It increases glucose delivery to the blood from its storage site. So it makes more sugar, more energy, nutrients available to be used by this active skeletal muscle. Posterior pituitary gland releases antidiuretic hormone, which allows for water balance, so that you can retain that water, keep that blood pressure nice and high, which corresponds to the fact that your urinary tract is going to be less active. And then the adrenal medulla is going to release more epinephrine and norepinephrine. So you're going to get more catecholamines that continue that response in the alarm stage. I always like to see tables that have the effects that the autonomic system has, because it's nice just to have that where you can go and turn to it. And so I've included it here. It's broken up into neurotransmitter, which really is telling you sympathetic nervous system versus parasympathetic. And the key difference here, the sympathetic nervous system is the fight or flight response. Parasympathetics are going to be the rest and digest. So you have a balance. These two things are constantly competing, and whoever is more predominant is going to be the state of that person's body. Now, once you move out of the alarm phase, you enter into the resistance phase. And this is where the body has gotten rid of or accommodated that stressor because it has a continual secretion of catecholamines, epinephrine and norepinephrine, through the activation of those endocrine glands. This resistance stage is time limited, meaning that if the stress leaves, the parasympathetic nervous system is going to predominate, right? Your sympathetic is going to become less active, your parasympathetic will become more active, and the person or the patient will enter into a state of relaxation, or at least more relaxed state. If that stress doesn't abate, you start to enter into the chronic stressor. And that's what can lead you to the exhaustion phase, where the stressor is not eliminated, body's overwhelmed. And what people who enter in this exhaustion phase will report is that they feel run down or overwhelmed and unable to cope. And this is where chronic stress and its maladies arise. Long-term chronic stress means long-term secretion of cortisol, which is immunosuppressive. Right? It's a steroidal hormone, and it, especially on T cells, it's good at telling them to stop. Right. Together with that, people who are chronically stressed are also, and this is just immune centric at the moment, but they're also at risk for increased infections because their immune system is going to become suppressed. And so this creates this nice axis where the hypothalamus, and this is in a tropic hormone setting, where the hypothalamus is activated to release a stimulating hormone that the anterior pituitary gland releases and gets the adrenal gland activated. All of this is occurring secondarily, but in close proximity to the activity of the sympathetic nervous system. And those two things together give us our alarm phase. And then as we enter into the resistance phase, and as the case may be, unfortunately, if we enter into the exhaustion phase, we get the long-term activation of our adrenal glands, which one part of that is going to be an increase long-term production of cortisol, can lead to immunosuppression, risk for infection. Now, Sales response is not the only one. McEwen's stress response theory is also available. It's actually much more recent. In the, I think, mid-90s, it was developed. It is an example of allostasis, which is the idea that a stress response is not just a set series of events based on whether the stressor was there or not. And instead, this is kind of a dynamic balance, right? We're taking into multiple stressors that occur, right? Because we know as organisms, we are constantly being exposed to stressors. And so the theory of this is that frequent stressors change your body's stress response set point. For example, if you have chronic stress, a person is going to have a newer, higher set point for their blood pressure. So their blood pressure is going to go up, so they're going to become hypertensive. And if you think about that, it kind of makes sense. If a person is under chronic stress, the body's going to say, man, we need a lot of blood to be flowing at high pressures much more often. We should just change, the body, I guess the hypothalamus should just change what is the set point for blood pressure. We're going to make it higher because it seems like we need it. And so the allostatic load is the idea of the combined wear and tear on the body's systems as a result of these stress reactions and the cumulative effect. And it's not only, the allostatic load is based not only on the actual stressor, but it's also on how able the individual, the patient is able, or how effective they are at responding to those stressors. So it's not just the influence of the stressor, it's also on the sufficiency of their response, right? And so two people could both be stressed with the same thing. And if I have a weakened stress response, my allostatic load will be higher. Or I will have more detrimental consequences than somebody who has better stress responses, like they're more sufficient. This allostatic load can accumulate numerous ways, right? The inability to adapt, repeated stressful experiences, progression into chronic stresses, right? So not only you keep getting stressed, but what about stresses that just don't go, and the body's response to them? If the stressor is gone, but let's take this emotionally or mentally, you still feel as if the stressor is there, you're going to get a prolonged reaction. in some cases, your body doesn't respond the way it should, right? So small things maybe evoke a very strong stress response, or vice versa, strong stressors don't evoke a strong enough response. And this can lead to allostatic overload. And that's the point where the stresses overwhelm the ability of the body to adapt. Many pathophysiological disorders can manifest into a stress response. But it's not just what's happening within the body. It can also be lifestyle choices, both to detriment, but also to adaptation, to coping mechanisms. So there are many chronic related stress disorders, which are on the slide, and I won't read them off to you, but know that many aspects of diseases will have a stress response. Again, McEwen's theory, the reason that it holds so much power is that it speaks to kind of the body and the stressors interacting together. So to treat stresses, you see a variety of ways to do that. Again, on here, some of my favorite that I do not follow: reduced caffeine intake. I don't do that. Probably should. I think I'm okay at work leisure balance sometimes. I should do more exercise, and I actually quite like yoga. But things like meditation, I do not do and cannot tolerate, because I can't get my mind to be still enough. And maybe I've never had anybody walk me through it. So there are a variety, walk me through it well, I guess. There are a variety of lifestyle practices that can be used to cope with stress. But really it's finding what works for an individual, right? We all have predilections that, that can guide us to a more successful response. And in some cases, stresses might need to be managed pharmacologically. And so with that in mind, what about the role of serotonin and tryptophan? Tryptophan's one of my favorite amino acids, that or glycine, because it's the easiest. Serotonin is a neurotransmitter in the brain. It is also produced in the GI tract. And during stressful responses, it's well characterized that levels of serotonin plummet. This is one of the reasons why people who are stressed, yes, they have a feeling of anxiousness and anxiety. They don't feel relaxed. But it's also why stress can also upset your stomach, because that serotonin production gets dysregulated. Tryptophan, again, the amino acid, is a precursor, and I've just borrowed this from this journal here. Tryptophan can be used not only to make proteins, but also not only to make proteins that our cells use for like structure, but they can also be used to make serotonin and also nicotinamide, which helps us make energy. And what's interesting is that eating carbohydrates help facilitate tryptophan being brought into the brain. So one of the reasons that you can't do a completely carb-free diet is that you need carbs for energy, and importantly, also for adequate brain chemistry, right? And so with serotonin in the background, right, its levels are depleted in stress. One way to treat it is to treat stress is to try to depress the central nervous system into the state of being relaxed. These would be like tranquilizers and downers. Alcohol can be a sedating substance, and you can see that sedatives may work in some cases, but they also carry with them potential for abuse or over medication at the behavioral level. Antidepressants also work. What they do, or what, depending on the type, they modulate neurotransmitters in the brain, serotonin and dopamine. Antidepressants carry with it that the effect of an antidepressant might not manifest itself until it's reached a therapeutic concentration in the blood. And some people will have a lesser, somebody asked, are we suggesting alcohol to reduce stress? If you partake in alcohol and partake responsibly, then maybe, yeah. I find, mine is context dependent. I'm not good at drinking while watching sports because it's too easy to go too far. But if I'm just stressed from a long day at work, a nice beer takes the edge off. Again, personally. Now, one thing for some people, I would argue that there's a lot of personal preference and just individuality here, is the use of exercise as a eustressor. I say in italics that exercise can be a use stressor. It can be a positive. For many people, exercising helps to blunt the anxiety that people fear. But exercise can also become a stressor itself, especially if it's being used to replace something else, and it becomes detrimental, because stress itself, or exercise itself, is a physical stressor applied to the body. Typical recommendation is 40 minutes, 3 to 4 times per week. This can be complicated if you have underlying health conditions, for example, cardiovascular disease or other metabolic diseases, where you would want to consult a physician to see, am I at a level where that type of exercise or any exercise at all is possible. There's lots of emphasis emerging on the idea of using exercise as a medicine, or exercise as a treatment. People like exercise physiologists consult with doctors and kind of work their way into that. What are some of the benefits? Weight control, your cardiovascular system gets better. In effect, it gets more efficient. Your gastrointestinal system becomes more efficient. It turns out people who exercise have a gastrointestinal system that is more efficient at peristalsis, so moving that stuff through. There are fairly good correlations with levels of exercise and a reduction in colon cancer risk. They kind of work together. Your lungs get better. And if you think about it, this makes sense, because if the body says, oh, I'm used to being stressed with this physical event, I should probably make my heart pump more efficiently and make my lungs work a little bit better. And it also increases endorphins, which is a psychological effect, but it's a consequence of having those endorphins released. And they're a neurotransmitter that helps with pain management and feelings of euphoria. Skeletal muscle system gets better. And from a metabolic standpoint, exercise is useful because the muscles say, hey, well, we're exercising. We need that glucose that is in the blood. And so glucose uptake by cells gets better because the muscle cells say, well, we need that glucose. And so you can see in some cases, diabetes can be managed, or at least it can be part of the management if you have some exercise. Now, the opposite side of exercise is immobility. There are lots of effects to this. Risk for collapsed lung, bones will resorb, heart muscles. If you don't use muscles, they're going to atrophy, as we saw in the last chapter. So the heart can decondition. Muscles can decondition. That can lead to, or not that can lead to, but other events of immobility or inactivity can be pressure ulcers. And I think it's this chapter we'll have a couple of words at the end about sores and lesions as a result of that. And those of you that are from the nursing profession, I know that is something that is, at least at some part in your nursing curriculum, is you spend a lot of time on, is the idea of managing the consequences of immobility. Many more that I won't read to you because I don't need to. So that idea of inactivity maybe best most drastically manifests itself on the circulatory system. You are at increased risk for blood clots and edema the less modal, the less active you are. One of the big reasons for this is that muscle contraction is what assists most of the blood moving through the veins, getting them to return to the heart to then be recirculated. And so you see inactivity, sitting too long or being too sedentary, you see risks for thrombotic events being especially prevalent. You also see natriuresis, which will go up. And this is the idea that if you are inactive, you tend to increase water loss because the hormones that drive water loss, the natriuretic peptides, overwhelm the water retention hormones, ADH and aldosterone, because they don't get produced to the same degree when you are inactive, because the body says, we don't need that water. And so these two water retention hormones go down, water loss occurs, and that has consequences to the circulatory system. and circular blood flow. With inactivity, again, because the heart's going to decondition, one of the things that it will do is it will have to work harder under stress. And so this is especially true with prolonged bed rest, that the heart will actually have to work, twice, 1.5, whatever times harder to return venous blood. And as that heart continues to decondition, you'll start to see venous return reduced. You'll start to see, coupled together with the muscles that are not as active. So you see circulatory effects become very drastic. And you see that maybe best, or see that manifest also with the pulmonary system, where lung volumes get reduced, ventilation becomes worse. You are at risk for collapsed lung and aspiration and choking. And then the musculoskeletal effects are a little bit obvious, because if you don't use it in that line, you lose it. And so you see shortening of muscles because they're not being stressed, so there's no reason for them to stay. Strength goes down. And then one of the interesting features is that you lose is trabecular bone. And what that does is it increases the risk for fractures, pathological fractures, as a result of thinning and deconditioning bone. And so with those joints and muscles, without activity, the joints, it turns out many places where you have opposers, where your forearms are good examples. You have the action of the flexors are being opposed by the action of the extensors. And maybe you did this in anatomy. Did you do the resting hand position? Like, what is the natural state of your hand if the extensors and the flexors are balanced? And so what the natural resting state is a slight contraction, or a slight flexion, excuse me. Because flexors tend to pull a little, they're at a better, more optimistic biomechanical angle, so they overwhelm the extensors. Well, that gets accentuated with inactivity, because now you lose, that difference in effect becomes magnified. And so what happens is you assume this fetal position, and there are things clinicians need to do to ensure that there's enough muscle tension to try to avoid that natural posture. More harmful effects of inactivity: kidneys become less effective at secreting, which raises the risk of UTIs. The GI system becomes worse because there is less muscle movement. Gravity itself helps to move some of that through. And then your inability to tolerate glucose goes up. Breakdown of muscle protein goes up, because the body says, we're not using it, we might as well get rid of it. And then one of the aspects of immobility that's maybe the most acutely present in a bed rest patient is the development of sores. And that's where you have these occur predominantly at places where there are bony prominences underlying the integumentary system, and it can lead to decubitus ulcers, which progress through 4 stages. You have a first stage. It's kind of and really these stages work their way deeper into the integumentary system and potentially beyond. So the first stage is this general redness, that erythema, more or less confined to the epidermis and maybe the underlying dermal layer. In stage 2, you have destruction of the epidermis and the dermis, and it's starting to encroach into the hypodermis, which is that fatty layer that separates, that's not skin, not part of the integumentary system, but separates skin from the underlying tissue. In stage 3, I had my things backwards. It's approaching into the dermis. In stage 3, that hypodermis layer has been encroached, which means now you have a complete break through the skin. And it can lead to stage 4, which is not only has the entire integumentary system been lost, but it's also encroaching into the underlying muscle and bone, right? So you're through the fascia, you're through the hypodermis, you're into the underlying tissues. And because these are going to be at pressure points, you're most likely going to have muscle and bone in those. I think I have, yeah. And so what this means is that in a immobile or bed rest patient, you're going to have frequent moving, because what you're trying to do is minimize the amount of contact, right? And so those of you who do, who have this training would know better than I. So I left what the text gave us as the recommendations, but frequent repositioning, extra padding in areas that are especially susceptible, together with using compression technologies to ensure that venous blood is able to return. Should the ulcer form, you treat the ulcer, and because what you don't want to have happen is the wound to become, or the patient to become septicemic, where wound becomes infected and that infection gains access to the bloodstream, because sepsis has very poor odds, relatively speaking. Some areas of concern. This is, again, in a prone patient, so just use your anatomy training that you all have had. If they were laying on a lateral side, or for some reason they were laying face down, where would the pressure points kind of change? But your heels, calves, sacrum, elbows, shoulders, and the occipital region are all points where you have pressure, because that's where contact is being made and bone is in close proximity. There's little gap between the bone and the skin in those areas. Immobile patients also can have detriments to their psychosocial status. They can they're more likely to become depressed or highly anxious or experience fear or mood swings. Also with bed rest, there's a link between the visual stimulation of the eyes processing to the brain, where concentration and problem-solving abilities can go down. Well fed, yeah, nutritional status. Yeah, because I had something to say, I don't remember, but yeah, maintaining adequate nutrition in whatever means can be achieved. Yeah, that's good. So as a personal point, I had a grandmother who had Alzheimer's disease, and near the end, she became, I forget what they called her type. She was a patient that wandered, so she didn't know where she was completely disoriented, but as a part of that, she was mobile and highly mobile, because she had not yet had those effects. And then as her disease progressed, she stayed healthy, even though her mind was failing her. She stayed healthy, so she avoided, she was okay, until it kind of progressed to the point in kind of quick needs where she had to be rested bed. And then she went from just being someone who was disoriented but happy-go-lucky. Her mood completely changed, and so she became withdrawn. And part of that, whether speculation or with evidence, is you lose some of that stimulation from seeing different things, getting around. So they can be there. Okay. Well, I went through that faster than I expected. I'm going to stop the recording here for a second.
Recording stopped.
Repetition and that redundancy, the better. And so why do we experience pain? That is a philosophical question, but from a evolutionary standpoint, it's the idea that it's a protective mechanism, because experiencing pain, if you did not know that there was pain in your toe, you as an organism might not give it any attention. And so pain is essentially the body saying, hey, something's wrong in this place, right? Pay attention to this. That's why pain is one of the cardinal signs of inflammation, because nerve endings get stimulated. And it's thought the reason neutrophils are good at activating pain receptors is so that the organism doesn't forget about it or avoid it. Patients that have deficiencies in the ability to feel pain typically have short lifespans, or are at big risk for major complications and fairly quickly. Pain is one of the most common symptoms for which people seek medical treatment, and there are optimal pain management strategies, and they are important, because if you manage pain adequately, the patient will feel better, they'll reach a level of functioning more quickly, and they'll have fewer complications. Pain is essentially a signal between the peripheral system that moves through the spinal cord and moves through the brain. There are simple reflex arcs for pain, and so this is best illustrated with like the hot stove reflex. If you put your hand on a hot stove, your body will pull it away before your brain has had time to know, oh crap, my hand, the hand was on something hot. And so a reflex arc is something that short circuits. It moves through the spinal cord, but does not ascend to the brain yet, right? It will, but it doesn't right away. Nociceptors are pain nerves. They're the typically free nerve endings that you find wherever pain can be sensed. And then again, the spinal cord is, that big thing in your spine. Pain signals are an ascending tract through the spinothalamic tract. You all did this in anatomy, but I always like to refresh us. How do you know which direction a tract is moving? What is the order of the suffix and prefix? Spino says the spinal cord to the thalamus, right? And so that's an ascending pathway because the spinal cord is lower than the thalamus. What does the brain do? Well, the brain does everything, mostly. But once it receives that pain message, it can evoke a response, but it can also send messages to modify that pain, depending on what other information is coming in. And one of the ways it does this is it stimulates production of endorphins, right? The body's natural painkillers. Neurotransmitters are who send messages of pain, but they also can inhibit pain signals. So that's how those pain nerves in the periphery communicate to the spinal cord, who then communicates through the thalamus into the cerebral cortex. Some examples of neurotransmitters: acetylcholine, GABA, serotonin. They can be excitatory or inhibitory, depending on which we have. So again, sure, this is a reminder, but we'll look at it. A simple reflect arc is really, and actually a simple arc, I think, is just 2, but we'll go with what our information has here. A simple reflex arc is a set of neurons that don't ascend to the cerebral cortex. And so in this case, we have our afferent motor, or afferent neuron. And so it's going to be here. It has these free nerve endings. There's a stimulus that needs to be dealt with quickly. It overwhelms the message, or it trips this simple reflex arc. That message gets sent through the dorsal root, and then it synapses to an interneuron. And that interneuron is what connects 2 neurons, typically in close proximity. The interneuron takes that message that's very strong to say, oh man, there's something bad happening here, and it immediately stimulates a motor neuron at that level to induce some sort of response, right, through the ventral roots. And so ask yourself, well, why would it do that, right? If I put my hand on a hot stove, why would my body have an evolutionary mechanism to pull it away before the brain knew what was wrong? Like, it's going to get to the brain fairly quickly, but why is it pulling it away? Well, it's because that signal is so strong, and we can now link strong signal meaning danger. Jeez, that scared me. That danger signal is so strong that you have a mechanism to get the hand off, and then you deal with what the brain would interpret later, right? So it's a preservation mechanism. The brain says, oh, well, it turns out that signal wasn't that bad, but it's better that we err on the side of less tissue damage than more. Hot stove reflex is my favorite, simple reflex arc, but just a simple patellar reflex, right? Anytime that you stimulate those deep tendon organs, you can induce equivalencies in that. My favorite from grad, I teach a neurological disease class sometimes, and it is when we do a review of pathways that you maybe did in anatomy. So we review these neurological pathways, and I always like using the idea of stepping on a Lego because that hurts more than anything else, I think. All right, so we have that simple reflex arc, but we know those pain signals are going to ascend. Pain pathways are interesting, are very similar to just general sensation pathways. They still take 3 neurons to go from the periphery to the spinal cord, to the thalamus, to the brain. I don't know that we don't get into it here, but what's interesting about pain pathways is that when the sensory afferent nerves enter into the spinal cord, they make a connection with a spinal nerve, or with a nerve within the spinal cord in the dorsal horn, but they don't just connect at the level they enter. So if I slam my middle finger in a door, that pain signal not only will travel up to my spinal cord at the C7 level, once it gets into the spinal cord, those peripheral nerves actually trifurcate. which means they not only send a message to the C7 level, they also send one to C6 and C8. And the reason they do that is redundancy, right? Pain is probably something that is concerning. And so by having it trifurcate, it ensures that even if something goes wrong at the C7 level, you got a chance that one of the other two redundancies will evoke a response, whether that's a reflex arc or sending it to the brain. Now, when that message goes up to the brain, once we're in the central nervous system, pain and general sensation crosses immediately upon entering. So pain crosses immediately upon entering. So it slips over in the anterior commissure, and then it flies up, and it goes up into the thalamus, and then it sends the third order neuron to the sensory area, your postcentral gyrus. So that tract to take us up is the spinothalamic tract, right? The collection of neurons that are ascending, taking information up to the brain. Well, the brain's going to process it. It's going to take that information, any other information it has. The brain is good at integration and interpretation. It's going to say all of this information collectively. I'm going to activate the motor areas to do something about the signal that I'm getting, whatever that effect is going to be. And those fibers are going to descend through the corticospinal tract, most of which cross, and they're going to go in and they're going to say, hey, muscle, contract to, stop holding that ice cold beer, put it down, right? You're hurting my hands. So what kind of information then is what's triggering the reflex arc? And this is the idea of nociception, which is the sensation of noxious stimuli, messages that convey pain. Nociceptors are pain receptors, and two examples are the A delta fibers and the C delta and C fibers. A delta are small, they're myelinated, they carry that initial acute, because they're small and they're myelinated, they send that acute signal very quickly, that you get that very fast message. The C fibers are a larger unmyelinated fiber, so they're going to carry the more diffuse, more dull, persistent pain signals. And we could argue, I don't know whether, or I could argue for or against, but the idea that acute pain signals are sent by the nerve fibers that can fire faster, because those are going to be the pain messages that are more concerning evolutionarily in the short term. That's what I always think. Now, those nerves that have received that stimulation, what kind of neurotransmitters are they going to send? There are 50 neurotransmitters or so involved in the sensation and responses to pain. Many of these can be pharmacologically manipulated so that you can manage pain. You might, for example, to treat migraines, take agents that increase serotonin, which blunts the consequences of that dural pain from migraines. So another table, which again, you all may have more detail at points. Oh, cool. All right. So we have our table of neurochemicals and neurotransmitters. What's interesting, right? What ties us back to what we just covered in the first spring term. Check out who we have here. We have interleukins, and we have tumor necrosis factor, and we have leukotrienes. We talked about those in the context of host defense and an inflammatory response, but what we see is that they contribute to an increase in pain. And the way they do that, this is why they might be more aligned with a neurochemical, is not necessarily that they stimulate pain receptors, although some of them can. It's instead that they stimulate the cells that themselves secrete things that can activate pain receptors. And if you think about why, right? If you have lots of interleukins and tumor necrosis factor being produced in an area, something's wrong in that area. And by indirectly or directly activating pain and sending that message to the brain, the organism is going to pay attention to it. Some of the other things you'll see here, substance P and glutamate and acetylcholine and enkephalins, are endorphins too. They're going to be more of our traditional neurotransmitters that we think of, not only with neural activity, but specifically with pain. So one of those things that the brain can produce is that not only does the brain receive information, but it can also induce a response that modifies that information. The brain can produce endogenous opioids, including endorphins or dynorphinins, enkephalins. And these substances blunt the sensation of pain, and they turn it down. They make those pain nerves less sensitive to their sensations. That endorphin response is maybe best, or in my case at least, is best characterized when you do long, arduous exercise. And what you get is that, quote, runner's high. And what you have then is, as you are running, you get to the point where the muscles are starting to ache. And right, why does the brain secrete it? And that's to alleviate some of that pain, which from a running standpoint, if you were fleeing from a tiger, it lets you keep going so that the tiger doesn't catch you. So what are the events that lead to that endogenous opioid release? I split this up a little bit different than, I've never done it, broken it up this way. So maybe this will work, I don't know. I split it up by region, right? So at the midbrain, which is where this endogenous opioid response can occur, the periaqueductal gray matter, which is the gray matter that is surrounding your cerebral aqueduct, it gets activated as a result of signals coming down from the brain to say, hey, there's some kind of pain response happening, do something about it. And it activates enkephalin releasing neurons, and these neurons project into the, I put medulla-ish, which is about where it is, but it's a big structure called the nucleus rapine magnus, or NRM. And so you have periductal neurons send a message down into the nucleus rapine magnus. And from here, you have a neuron that descends into the spinal cord that is going to secrete serotonin, right? And those these serotonin secreting descending neurons stimulate an inner neuron, which the inner neuron is who actually secretes the endogenous opioids, right? And so what they do is that these regulatory inner neurons secrete a message that makes this C fiber neuron, or C and A fiber, what makes this pain neuron be less able to communicate that message back up into the brain. So you get to the point where your body is like, oh, this keeps hurting, and then the brain says, whatever that is, we have dealt with it and we don't deem it a concern, turn the pain down. Like we don't need to hear it anymore, which is cool. So that is tolerating. You can also have sensitization, which can exaggerate, or you can sensitize, which you can both exaggerate pain nerve fibers. You can also, you will do that primarily through decreasing the inhibition of those pain signals. There are desensitization consequences in different disease states, right? Where pain signals aren't getting gathered. Arguably, the one that is probably that comes to mind first for me right now, at least, is the idea of like diabetic neuropathies, right? How is it that these ulcers are able to develop and don't seem to hurt, right? And that's because the neurons, for reasons related to glucose abundance, have become damaged, and they're not firing right, so those pain signals are not coming up. And so the individual has an ulcer that they don't know about, or that doesn't hurt, right? So in that case, the organism's not giving it attention, and that can progress into myriad consequences. Yeah. All right, we'll finish here for today with dermatomes, and that way we're early. Man, we went through it fast. You all did dermatomes in anatomy, right? I'm sure. I don't know if this map matches approximately what map you had. Kind of the rule of thumb with dermatomes is it is variable depending on the text and depending on the person who mapped it. There might be slight differences. So what you do is you kind of go to general areas that are more or less consistent. For example, middle finger is always C7, tip of the thumb is always C6, so on and so on. And so what dermatomes do is they speak to a specific pattern where you say, this region is related to this spinal segment, this spinal nerve. And so you can map them based on location. And what that does is it gives you a way to test the sufficiency of spinal nerves, right? You can do a pinprick test on the middle finger to say, is there C7 nerve? Like, is there a deficiency or is there a hyperactivity in it? You can do that. You can also do that with deep tendon reflexes too, that can be mapped in specific places. I think we will stop there if that's all right. Is that okay? Yeah. All right, good. So